So starting with fertilization, when you do follicular monitoring, the aim is to tell the date of ovulation so that fertilization can happen during that period. So once ovulation happens, fertilization occurs, and then the division starts. So day 2, division has started, and then we have the blastocyst stage, okay, at around 5th day. Now you have two things. One is inner cell mass, and the other part is the trophoblast. Inner cell mass is the one which will be forming the fetal pole. So this is the one which will give rise to our fetal pole. And trophoblast is the placental component, right? Now the trophoblast will further divide into two things, in situ trophoblast and cellular trophoblast. Cellular trophoblasts are the one which will form the chorionic villi. Do you see these yellow things? Now they are going to penetrate and form villi. And the syncytial trophoblast is going to digest the endometrium and will produce the lacunae where the maternal blood will fill. So they are going to line that area, and they are the reason why beta HCG is produced. So both do their functions. Now we are more concerned about the inner cell mass at this point of time. This is going to divide and form the fetus. So it is going to pull away from this trophoblast and will form a central disc and will now start forming few structures which we pick in our early ultrasound. Now I want you to name the signs of the images. Now these are classical spotters, and they help you tell the clinician that yes, this looks like early, very early GSAC. So what does this first image point to? I'll help you. This is uterus. This is uterus. We have two things. If you notice, a small cystic area in the endometrium, but not exactly in the endometrial cavity. So what is this ecogenic area? This is the collapsed endometrial cavity. So it is located on one side. So this is a cystic structure. Now this presentation is having a classical name. And as it ages, after some time, you see two rings. Very good. So it's an eccentrically placed cystic structure, which gives me intradecidual GSAC sign and tells me that this is more or less a true GSAC. Had it been centrally, it can be the pseudo GSAC or just a fluid accumulation within the endometrial cavity. So eccentric placement helps me. What about the second image? What do you see here? You have two rings. There is an anechoic area in between. Very good. Now let's discuss this sign. So the location of this GSAC is very important. It is eccentric. Eccentric to what? This hyperechoic line. So what is this hyperechoic line? The hyperechoic line is basically the collapsed endometrial cavity, and your sac is located eccentrically. Now, since it is eccentric, it is called as intradecidual sign. Okay. So the first image was pointing to intradecidual sign, and this is the earliest sign that you will get when you are having it, when you're doing a scan of intrauterine pregnancy, earliest sign. And the second one, you rightly pointed out, you have two ecogenic rings. One is this, and the second one is outer ring. So inner ecogenic ring, this ring is basically the trophoblast, the chorion and the decidua capsularis together. And the outer one is decidua vera along with the endometrial lining. So these two rings will give us a more specific sign. This is a more specific sign than the intradecidual GSAC sign. Okay, so this is known as double decidual sac sign. So two ecogenic rings. Now this is the chronology. First, when you're doing a scan, say at 4 weeks, you might see this small eccentrically placed sac, and as it grows, it becomes this double decidual sac sign. So you have two layers of ecogenic rim. Normally, the sac is very well defined round cystic structure. It will appear smooth. The thickness of this decidual reaction, this area, should be at least 2 mm or more than 2 mm. If you are writing in your report, good trophoblastic reaction is seen, good decidual reaction is seen, that means you are telling them that this is at least more than 2 mm, and the position should be in upper uterine body. Okay, so upper uterine cavity. Now I have two images in front of you, A and B. Can you tell me which structure is being pointed out? The A is very easy. I guess everybody will tell me. What is this structure? And then what about this? The second one. First is right. This is yolk sac. Good. And the second one, I'm seeing two parallel lines. What is this? Now we are dealing with early pregnancy only. So everybody is UPT positive in today's images. So what is this? Two parallel ecogenic lines within the G sac. This is also yolk sac. And these both are representing normal yolk sac. So when you're doing the scan, again, chronology. So eccentric G sac, then double decidual sac sign, and then you will have these tiny parallel ecogenic line, which will eventually show you a good rounded cystic structure, which is yolk sac. So both are yolk sac. It's just about the development. So it has started developing here. So it appears like two parallel equal lines, and then it becomes round cystic structure. So yolk sac. Okay. Now I have a, so one, okay, fetal pole, you could say, okay. So let's start labeling now. So first, everybody is clear. It's an eccentric circular structure, which is yolk sac. Then third is the fetal pole, obviously. Now, those who have said that fourth is amniotic membrane, congratulations, very good. Now, what is two? It was this G-sac. Okay, trick question. Now, chocolate question is, what is this cavity in which the entire thing is present, enclosing the G-sac? What is this star? So, amniotic membrane, fetal pole, yolk sac, G-sac, some trophoblastic reaction on all sides, uterus. What about this star? As we learn the embryology, we'll get to know. Meanwhile, so now the inner cell mass has separated from trophoblast and has formed a central plate. On either side, you have two cystic structures developing. Very good. So on either side, you have two cystic structures now developing adjacent to the fetal pole. So this inner cell mass is the fetal pole. So one is yolk sac, one is amniotic cavity, that is the amniotic sac, and the other is yolk sac, and everything is enclosed in the chorionic cavity. Now the same thing is present even on ultrasound. Now this is an ultrasound image. If you see, you are seeing two cystic structures flanking a central fetal pole. So one is yolk sac and the other is the amniotic cavity, and they are all surrounded and are present within the chorionic cavity, and the outer part is the trophoblastic. So this embryology we are able to see from this point of view in ultrasound. So are you able to correlate everything? So when the inner cell mass has pulled itself off, you have amniotic sac on one side and you have the yolk sac developing on the other side. So two cystic structures on either side of the fetal pole, and chorionic cavity is going to surround it. So that is the early development. And following that, as the development progresses, we have few more structures coming up. So this now I think everybody knows is the amniotic membrane, right? Okay, so this is amnion. This eccentric hyperechoic area is the developing trophoblast going to form the placenta. This ecogenic structure is clearly the fetal pole, the embryo, and cystic structure is the yolk sac. Now we see two linear ecogenic areas. One is connecting the fetus, developing fetus or embryo, to the yolk sac. and the other one is connecting this fetal pole to the placenta. What are these structures? This is 1 and 2. Again, chocolate questions. So the structure that is connecting your fetal pole to yolk sac, and the structure which is connecting the fetal pole to placenta. What are these? Very good. Which one? Which one is the cord? When you're doing a ultrasound, early pregnancy ultrasound, do you just look at the fetal pole and take fetal heart rate and your scan is done? Or do you look at the anatomy also? We are dissecting the anatomy till the embryology today. Excellent. Very good. Yes. So the one which is connecting the pole to placenta is umbilical cord, obviously, and the other is phallomesenteric or the vitelline duct. Great. So now your fetal pole, the inner cell mass has started dividing, and you see the vitelline duct, which is basically connecting the future midgut to the yolk sac. And that is why the structure which is connecting the fetal pole to the yolk sac is vitelline duct, and the other one was umbilical cord. If this vitelline duct does not obliterate, it remains as mechal diverticulum. Okay, now we'll see our ultrasounds. So this structure is yolk sac and fetal pole. So the structure which is connecting the fetal pole to the yolk sac is nothing but the phallomesenteric or the vitelline duct. The structure which is connecting your fetal pole to the growing placenta is the umbilical cord. Okay. If there is, see, you can see the amnion and chorion separately. Now this is the amniotic membrane, right? And this is the chorion. So if you are seeing it separately, it is normal till what duration? Till 13 to 14 weeks of gestation. If it is separate beyond 14 weeks, then it is associated with chromosomal abnormalities. So till the NT&B scan, separation should not be seen. You can remember that way. But after 14 weeks, they should not be separated. If they are separated, then definitely there is a pathology. So we saw two structures. Now the baby has further grown. This is a CRL of 17 mm, and we see some other labeled structures. So let's start labeling. 1, this clearly. Then you see some structures on the either side of the baby. Anechoic area. So this is 2, 3. Yes, let's label these 3 structures. So 1, which is enclosing the baby, is amnion. Now what are these things? Small structures adjacent to the fetal pole. They are the future limbs. Excellent. And what about this anechoic cystic area within the fetus? Holoprosencephaly. Yes, very good. So this structure tells me which part is going to be the head and which part is the rump. So crown rump differentiation comes from this structure. So what is this anechoic area? So you are seeing a normal amnion with fetal pole. You have measured the CRL, which is the calipers, basically these caliper. We'll discuss that also. So this anechoic cystic structure is nothing but the rhombencephalon. So this rhombencephalon is the precursor of development of brain, and it will tell us which part is cranium. So this part is the cranium, and this is going to be the rump aspect. And as you rightly pointed out, these 4 structures are nothing but limb buds. Okay. So now see, our fetus has been expanding further. Sometimes you may see the fluid being little echogenic. So some diffuse ground glass echos are present. It's normal. Don't mistake it for hemorrhage unless clinical signs are present. Okay. So this was our timeline of the development. So you started with a cystic. So you started with an eccentric cystic structure. See, intradecidual sac sign, which is an eccentric placed G-sac. Then you will have 2 trophoblast double decidual sac sign. As 5 weeks, mid 5 weeks comes, so yolk sac becomes apparent by 5.5 weeks. The moment you see yolk sac, you can tell the female, congratulations, it's a confirmed intrauterine pregnancy. However, we need to assess the viability, and that will be done 7 to 10 days later. Okay, so by 5.5 weeks, you know that this is an intrauterine pregnancy. Going further, so you follow up after 7 to 10 days and you see a small fetal pole with cardiac activity. Now, viability is also assured. As the fetus begins to grow, 8 to 10 weeks, you start seeing Roman-Kefler and small limb birds. So this is the natural development, and we know this part is the head and this is the rump. Then she comes for NT&B scan, where we can see the fetal head and the curvature better. You see for the nasal bone. What if she comes a little earlier? Then you can see physiological gut herniation. And when does yolk sac disappear? After 13 weeks, yolk sac is no longer visualized because amnion fuses with chorion. Yes. We have a slide on subchorionic hemorrhage also. If you want to know in double decidual sac sign, if somebody is mistaking this as double decidual as subchorionic hemorrhage, no, this structure is basically not subchorionic hemorrhage. It is the endometrial cavity which is now getting collapsed. It will eventually fuse. Okay. So that was about the timeline. This is what we see. So at whatever point you are touching the pregnancy, you're doing the scan, you might start at very early, then assess the viability. Sometimes they come late, and then you can see the anatomy also. And first trimester scan is all about anatomy and the morphology. Okay, so this is the timeline. You can go through this slide. Now starting with the GSAC. So these two signs we already discussed, intradecidual and double decidual sac signs. So they were used when we did not have TVS. So often the yolk sac was missed on TAS. So they helped us to diagnose presence of intrauterine pregnancy earlier. But now, with the advent of good modern TVS, we can pick them even early. So GSAC, normally it should be round, oval, smooth, and decidual of 2 mm or greater. However, if there is abnormal appearance, irregular, small GSAC, how do I know that this GSAC is small? We have a qualitative criteria also, not just by appearance. So quantitatively, the MSD, mean sac diameter, should be equal to or greater than 5 mm as compared to the CRL. Okay, if it is not, if it is less than, the difference is less than 5 mm, you know that the GSAC is small. You see, it appears crowded also. You see a yolk sac, fetal pole, and this GSAC appears very small. And the third is the decidual reaction being thin, less than 2 mm. So you know that these are the abnormal appearances, and they can point to a poor outcome. This is very important when you're doing a scan for female who has undergone IVF. So from the very beginning, they will keep asking you, is it going good, your gynae colleagues? So you should know by the appearance of gestational sac, which patient needs more support. Okay. Now coming to yolk sac. Yolk sac is the next structure that you see after the appearance of a small cystic gestational sac. And that is visible by 5 weeks, 5 days onwards. So initially it appears as 2 echogenic lines, like equal to sign, and then you see the round cystic structure. It will keep on enlarging until 10 weeks, but how it will measure up to 5 to 6 mm only. At 10 weeks, it will start decreasing, and beyond 14 weeks, you don't see yolk sac. Is that clear? So till 10 weeks, yolk sac is very prominent, and then it goes on decreasing in size, becomes shrinked, and after 14 weeks, you don't see it. So that was our timeline. 5th week, 5.5, you started seeing yolk sac, and by 14, it is no longer visualized. So that was the normal appearance. Abnormal appearances, yolk sac can be very small. If it is small, then in some cases it has been seen that if it is less than 2 mm, it is associated with poor outcome. Large yolk sac, especially over 7 mm, is associated with poor outcome. Okay. If yolk sac is absent, again, poor marker. If yolk sac is very ecogenic, it can be a calcified yolk sac, failed intrauterine pregnancy. If your yolk sac is, see, ecogenic as well as irregular, but it's a variation in the appearance of morphology and it does not really correlate with the outcome. So these are the variable abnormal appearances, and you should know which points out to a dismal outcome. Most importantly, the large yolk sac. It tells that the pregnancy is not going good. So now yolk sac, even before the appearance of fetal pole, tells me about the multiple gestation. So visualization of multiple yolk sac is the earliest sign of multi-gestational pregnancy. Number of yolk sac tells me the number of amniotic sacs. Okay. So first trimester is the time where you tell the chorionicity and amnionicity. Now this is your test. This is the first image. It shows me two yolk sacs and a single cavity. So which type of gestation, twin gestation is this? Okay, very good. You have two yolk sacs. Yolk sac matches amniotic sacs. Yes. So this is showing us a single chorionic cavity with no intervening membrane. So monochorionic, is this clear? Single cavity, monochorionic. Two yolk sac, so two amniotic cavities. Monochorionic, diamniotic. Are we together? Hmm? Now this is the second pregnancy. Again, I'm seeing two yolk sacs, but I also see the chorionic cavity being split and a triangular ecogenic tissue indenting this membrane, forming a lambda sign. Now what is this? So chorionic cavity, two yolk sac, so two amnion, so diamniotic, dichorionic. A trick question. Third, you see two fetal pole here. So twins. However, how many yolk sac can you see? Hmm? So what is this? One chorionic cavity, monochorionic. One yolk sac, one amniotic cavity. So monochorionic, monoamniotic. So just by scanning in 5 to 6 weeks also, you can exactly tell, is it monochorionic, diamniotic, dichorionic, diamniotic, or monochorionic, monoamniotic with the help of yolk sacs and the cavity. And the first trimester is actually the easiest time to determine the chorionicity and amnionicity. Okay, this is how you do it. Coming to the fetal heart rate, by 6 weeks, you are usually detecting the fetal heart rate. Normally, it should be above 100 beats per minute. If your gestation is less than 6.2, otherwise it should be over 120 minutes. If the fetal heart rate is less than 90, some books say 100. If it is less than that, then this is, you have to give the diagnosis of bradycardia. Again, poor outcome. So just do follow up after a week, 7 to 10 days, and look for the viability. Now you see two images. Both are used to assess the fetal heart rate, A and B. Which one is better? Okay, I will. So if you are doing a scan before 6 weeks, heart rate should be over 100. And if you're doing after 6 weeks, say after 6.2 weeks, it should be over 120. The cutoff is 100. If the heart rate is below 100 persistently, then this is bradycardia and it can point to a poorly developing, failed early pregnancy. So if there is bradycardia, do a follow-up. So we have two things, A and B. And now I want you to tell me which modes are we using, which ultrasound modes are these, and which one is better, and why. So A is M mode, very good. This is M mode, and this is okay. So pulse. Okay. But my patient wants to hear the first heartbeat. It is such an emotional moment. They want to hear the heartbeat of the baby. So is this better or is this better? B is better. B is better for patients. They get happy, but not radiologically. Safety purpose, no. This is for hearing. They'll like to hear, but it is not safe. Always when you are doing below 10 weeks, we'll follow M mode. Which principle are we following? Alara. Why? We'll see. So fetal heart rate, M mode is the preferred one because these images, the tuck tuck, the sound and the intonation, whatever you're doing is having a higher power output. Just compare M mode 121, color and pulse Doppler 340, 1600. See how many times. Okay. So it's very important. If it is required, then you can use, but in early pregnancy, always go for M mode. Don't go for spectral. So are you aware what represents what in M mode? Where do we measure? Why am I measuring at this point? Because when you are a beginner, it is difficult to use M mode to detect heart rate until unless the heart rate is very brisk and you get nice lines. What if it is feeble? Then it's little tricky, and these images will help you read the M mode. So keep focusing on the image. So the first one, this 1A, this is the chorionic reaction, and on M mode, you will have it as hyperechoic. So hyperechoic area on grayscale image is corresponding to the 1B, the hyperechoic area in the M mode. Same way, the 2A and 4A, basically the chorionic cavity, is going to correspond to hypoechoic areas on M mode as well. This is the fetus, right? The pole, and this is a hyperechoic on grayscale. So this will appear hyperechoic on M mode also. So now when you are doing the scan, you know that the area of interest lies in between two anechoic or hypoechoic areas, and you will be focusing on this. So the echoes which are encountered in this frozen line will be mapped and will create this wavy pattern. So this rhythmic echoes are going to help you take the fetal heart rate. So trough to trough or two subsequent waves. This is basically, if you see your machine in the left corner, you have something called HR cycles. It can be set to 2 or 1, and depending on that, if it is 2, then you skip one wave and measure. Otherwise, the way they have measured is fine. So this is how you do an M mode. Doing it is very easy. Reading it sometimes for the beginner is tough. So the same thing is represented on M mode. The echogenicity is same. So in midway where you have rhythmic echoes, just measure it. Okay. Now we have another structure which we have already discussed. This is a rhombencephalon, a structure which is connecting the fetal pole to the placenta, developing placenta, umbilical cord, and see this is the wrinkled, atrophying yolk sac, the vitelline duct.